Welcome to the deep dive. We're jumping straight into a really crucial area for your revision today, hepatocellular carcinoma, or HCC.
It's right.
We've got our notes ready, going to pull out the key info you need to, really get a handle on this.
Exactly. And HCC, well, it's the most common primary cancer of the liver.
Right.
It starts right there in the liver's main cells, the hepatocytes. Makes up about 90% of primary liver cancers.
Wow, 90%.
Yeah. And globally, it's huge. Ranks as the third most common cancer overall. So definitely something you need to know about.
Okay, so it's definitely connected to existing liver issues, isn't it? That seems key.
Absolutely. Spot on.
Yeah.
The vast majority, we're talking 90, maybe 95% of cases they develop in people who already have some kind of chronic liver disease.
Mostly cirrhosis.
Mostly cirrhosis, yes.
Yeah.
It's pretty rare for HCC to just pop up in a completely healthy liver.
Good to know.
And while HCC is the main one, just remember there are others like hepatoblastoma in kids and cholangiocarcinoma in the bile ducts. But like you said, our focus today is giving you a solid, high-yield overview of HCC for your revision.
Right, so let's get crystal clear. Definition first. HCC in a nutshell.
Simple terms. Cancer starting in the liver's main cells, the hepatocytes.
Hepatocytes. Got it.
And like we said, most common primary liver cancer, hepato for liver cells, carcinoma for that type of cancer. Easy enough.
Makes sense. Now let's dig into what actually causes it, the etiology.
Okay, so the main driver, overwhelmingly, is chronic liver disease. Cirrhosis is the biggest culprit here.
Right.
Think of it like long-term damage and inflammation, just creating this environment where things can go wrong.
And what causes that inflammation?
Well, the big players causing that chronic inflammation are infections, especially hepatitis B and C viruses.
Okay. Viral hepatitis.
Exactly. Then there's liver damage from alcohol, of course, and increasingly non-alcoholic fatty liver disease, NAFLD.
Right. And NAFLD seems to be everywhere now.
It really does. And that can progress to NASH, which is more serious inflammation, and then cirrhosis. So that journey to HCC often starts way back with these chronic issues. Managing them is critical.
You mentioned Hep B and C. Are there, geographical differences there, important ones?
Yes, definitely. Globally, chronic Hep B is the #1 cause of HCC.
Okay.
But if you look at Europe, for example, chronic Hep C tends to be the more frequent cause.
Ah, that's a useful distinction for exams, maybe.
Could be, yeah.
Yeah.
A key geographical thing to keep in mind.
Okay. What else contributes beyond the viruses and NAFLD?
Well, significant alcohol intake is definitely up there, sometimes even if full cirrhosis hasn't developed yet.
Really? Even without cirrhosis?
Yeah, it seems so. Then you've got conditions like genetic hemochromatosis, that's the iron overload one.
Right.
Primary biliary cholangitis, used to be called primary biliary cirrhosis, and exposure to something called aflatoxin.
Aflatoxin? What's that?
They're toxins from certain molds, can contaminate food crops, especially in certain parts of the world.
Okay. Anything else? Rarer causes?
Yeah, there are a few others that sort of nudge the risk up, things like metabolic syndrome, diabetes, smoking.
The usual suspects in some ways.
Kind of. And then rare stuff like androgenic steroid use, primary sclerosing cholangitis, alpha-1 antitrypsin deficiency, maybe oral contraceptives in some cases, and porphyria cutanea tarda. It's a bit of a list.
It is quite a list. So if we're trying to build that mental picture for revision, what are the absolute key risk factors we need to lock down?
Okay, for a high-yield list, think chronic Hep B or C, heavy alcohol use, obesity, type 2 diabetes, metabolic syndrome, that aflatoxin exposure, and crucially, cirrhosis from any cause.
Cirrhosis is central then.
Absolutely central. Also at hypertension, IV drug use, mainly thinking Hep C link there, and maybe certain meds like the contraceptive pill or anabolic steroids.
Okay.
And don't forget NASH, the fatty liver inflammation, and those inherited conditions like hemochromatosis and alpha-1 antitrypsin deficiency.
Right, that's still quite a bit to remember. Any way to sort of group them or have a mnemonic?
Mnemonics are always tricky. How about, let's try. Haven't caught many bad habits, genetic. Maybe.
Okay, let's hear it. Haven't caught many bad habits, genetic.
So H for hepatitis B and C,
Okay.
A for aflatoxin, V for virus, just emphasizing Hep B, C again,
Right.
E for ethanol, alcohol, N for NASH, T for type 2 diabetes.
T. Okay.
Yeah, maybe think diabetes. Then C for cirrhosis, A for anabolic steroids, U for usage, IV drug usage,
Okay.
G for genetic hemochromatosis, alpha-1, H for hypertension, M for metabolic syndrome, B for birth control pills, D for other diseases like PSC, porphyria.
Wow. Okay, that's That's quite the stretch.
It is a bit of a stretch, isn't it?
Yeah.
But maybe some of those letters help peg the main ones. Haven't caught many bad habits, genetic. Worth a shot.
Huh, maybe. I like the effort. Okay, let's zoom in now. Cellular level. How does this damage actually turn into cancer? The pathophysiology?
Right. So it usually starts with that chronic liver damage and inflammation we talked about. Over time, this constant injury can lead to these things called dysplastic nodules. Think of them as precancerous areas, warning signs.
Okay, like abnormal cell clumps.
Exactly. And then some of those nodules can change further and become actual HCC.
What drives that change?
It's all down to molecular alterations, genetic mutations. Basically, the normal controls on how hepatocytes grow and divide just get broken.
The cells go rogue.
That's a good way to put it. It's a complex mix of genetic changes to the DNA code itself, and also epigenetic changes.
Epigenetic.
Yeah, those are changes that affect how genes work without changing the DNA sequence, like switching genes on or off inappropriately.
Ah, okay.
So you get oncogenes, the accelerators for cell growth switched on, and tumor suppressor genes, the brakes switched off.
And the chronic inflammation just makes this more likely.
Precisely. That whole environment of constant cell turnover and damage just increases the chances for these genetic mistakes to happen and stick.
Okay, makes sense. So we understand how it develops. Now, thinking clinically, if someone presents with liver issues, what else is on the table? What's the differential diagnosis?
Good question. You've got to consider several things.
Yeah.
Obviously, cirrhosis itself, just a background condition.
Right.
Then other primary liver cancers, cholangiocarcinoma for the bile ducts, and hepatoblastoma, especially if it's a child.
Okay.
And really importantly, metastatic tumors. Cancer that started somewhere else, like the colon, lung, breast, and spread to the liver. That's actually more common than primary liver cancer in many places.
Ah, okay. Mets are key.
Very key. Then you have benign liver tumors, things like hepatic adenomas or focal nodular hyperplasia, FNH. They could look like lumps on scans, too.
Benign ones, too.
Yep. And then just broadly, any other cause of liver dysfunction needs considering. And, though it's rare, primary lymphoma of the liver.
Wow, quite a differential. Any quick tips for sorting through that in an exam?
I'd think. Where did it start? Liver cells, HCC, bile ducts, cholangio, somewhere else. How old is the patient? Hepatoblastoma. Is it likely benign or malignant? Thinking about the cell type in primary versus secondary helps narrow it down.
Useful framework. Okay, zooming back out. Epidemiology. How common is HCC, say, here in the UK versus globally?
So in the UK, it's relatively uncommon compared to, say, lung or bowel cancer. But the numbers are going up.
Why is that?
Likely linked to rising rates of obesity, NAFLD, and maybe historical Hep C infections. It tends to affect older adults more, especially those with that background of chronic liver disease or cirrhosis.
And globally, you said it was a big player.
Huge differences globally. In high-income countries, maybe 3 cases per 100,000 people.
Okay.
But you go to parts of Asia and Africa where Hep B is endemic. The rates can skyrocket. 78 per 100,000, even higher in some places. Up to 120 per 100,000 has been reported.
That's a massive disparity, driven by Hep B mostly.
Primarily, yes. Chronic Hep B, often acquired very early in life, is the major driver there. Whereas in Europe and North America, historically, Hep C played a bigger role, though hopefully that's changing with better treatments.
Right.
Other global factors pushing rates up are IV drug use, spreading Hep C, aflatoxins in some regions, alcohol, and that global rise in obesity, diabetes, hypertension driving NAFLD.
So overall, it's the third leading cause of cancer death globally.
That's the statistic, yes. Highest incidence in Asia and sub-Saharan Africa. Much less common, relatively speaking, in Europe and North America.
And how long does it typically take to develop? You mentioned it's slow.
Usually, yeah. Often takes 20, maybe 30 years after the initial liver damage starts.
Okay.
Average age at diagnosis in the UK is around 66. And interestingly, it's much more common in men, maybe 4 to 8 times higher incidences than in women.
Wow, that's a big difference too.
It is. And while it's mainly an adult cancer, remember it is the second most common liver malignancy in kids, often linked to their own underlying liver conditions.
Right. So what signs and symptoms should make you suspect HCC? What are the clinical features we look for?
Okay, this is a really important point. Early stage HCC is often completely asymptomatic, no symptoms at all.
Which is why screening is important.
Exactly, because it often gets diagnosed late. As it agresses, symptoms related to the underlying cirrhosis or worsening liver failure start to show up.
Like what?
Things like jaundice, the yellow skin, and eyes. Ascites fluid buildup in the belly, pain in the right upper abdomen, an enlarged liver, hepatomegaly, itching, pruritus, maybe enlarged spleen, splenomegaly.
Okay.
Or sometimes someone with known chronic liver disease just suddenly gets worse. That's called decompensation. That could be a sign HCC is developed.
Are there specific blood tests or signs on examination?
Yes, the key blood marker, though not perfect, is alpha-fetoprotein, AFP. Elevated AFP is suggestive.
How high?
Well, normal is low, maybe under 10 or 20.
Hmm.
Very high levels, like over 400, are quite specific. But many HCCs, especially small ones, don't produce that much AFP. Sensitivity is maybe only 60%.
So you can't rely on it alone.
Definitely not. Other symptoms can include weight loss, confusion, that's hepatic encephalopathy, more abdominal swelling from the sites, maybe bleeding from esophageal varices.
And physical signs?
You might see signs of chronic liver disease, like spider naivety on the skin, swelling in the ankles, peripheral edema, maybe anemia, prominent veins around the belly button.
Caput medusae.
Yeah, those periumbilical collaterals. And a flapping tremor asterixis if they have encephalopathy. If the cancer has spread or metastasized, symptoms depend on where it's gone.
Where does it usually spread?
Most commonly lung, the portal vein itself, nearby lymph nodes, bone, and sometimes the brain. On exam, you might feel an enlarged, maybe irregular liver, or even a distinct mass.
Okay.
And just to reiterate for those high-risk groups, people with cirrhosis, screening every 6 months with ultrasound, and maybe AFP is crucial for early detection.
And diagnosis? How is it confirmed?
Usually needs histopathology, a
Yeah.
biopsy sample, or specific imaging criteria on CT or MRI, especially if the person already has cirrhosis. A typical enhancing lesion in a cirrhotic liver on imaging is often enough.
Okay. And staging. You mentioned TNM.
Yeah, TNM is standard.
Yeah.
T for tumor size spread, N for lymph nodes, M for metastasis. Each gets a number, T1 to T4, N0 or M1 to describe the extent.
Got it. So if someone presents with red flags or something shows up on screening, what investigations get ordered?
Right, so for screening in those high-risk groups, cirrhotic Hep BC, alcoholic cirrhosis, maybe some non-cirrhotic Hep B carriers too, it's usually ultrasound every 6 months, sometimes 12, often with AFP blood tests alongside.
And you mentioned the limitations of AFP. How good is ultrasound?
Ultrasound is pretty good. It's the preferred screening method. Sensitivity maybe 60–80%, but specificity is better, over 90%. Combining with AFP probably improves detection slightly.
Okay. And for actual diagnosis if something is found?
Well, if you see a new focal lesion, a spot in a cirrhotic liver on imaging, that's immediately suspicious. If it's, say, bigger than 2 centimeters on ultrasound and the AFP is clearly elevated, that's often considered diagnostic enough to start treatment planning.
And if it's less clear?
Then you need better imaging to really characterize it. Usually a multi-phase, contrast-enhanced CT scan of the abdomen and pelvis, or an MRI with liver-specific contrast.
Why contrast?
HCCs often have a very specific pattern of how they take up and wash out the contrast dye, especially in the arterial phase. That helps distinguish them from other lesions. You'd also usually get a chest CT to look for lung mets. Sometimes angiography with lipidol is used, particularly if planning TACE.
Lipidol.
It's an oily contrast agent that can stick in HCC tumors.
And biopsy, is that always needed?
Not always. If the imaging in a cirrhotic patient is classic for HCC, a biopsy might be skipped because there are risks bleeding and a small risk of spreading tumor cells along the needle tract called seeding. But if the diagnosis is uncertain, a biopsy is definitely done.
Okay. What about other blood tests?
Standard liver function tests, LFTs, are essential. They'll often show abnormalities reflecting the underlying cirrhosis. Also check clotting factors like INR and albumin levels, as liver function affects these.
Right, measures of liver function.
Exactly. And maybe a chest x-ray, which might show a raised diaphragm on the right side if the liver is very large, or visible lung mets.
And you mentioned staging systems beyond TNM, CLIP and BCLC.
Yes. The CLIP score uses Child-Pugh score, which grades liver function plus tumor features, AFP, and portal vein thrombosis to predict survival. The BCLC Barcelona Clinic Liver Cancer System is very widely used because it doesn't just stage, it actually links the stage to recommended treatment strategies. It considers tumor stage, liver function, and the patient's overall fitness or performance status.
That sounds very practical.
It is. It really helps guide management decisions.
Okay, so that leads us nicely into management. Once it's diagnosed and staged, what are the treatment options?
It really depends heavily on the stage and, crucially, the patient's liver function. How bad is the underlying cirrhosis?
Makes sense. What about early stage?
For early stage HCC, where the tumor is small, maybe just 1 or 2 nodules, and liver function is reasonably preserved, Child-Pugh A or maybe early B, you can think about potentially curative treatments.
Like surgery.
Exactly. Surgical resection, Cutting out the tumor is an option if enough healthy liver will be left behind. Liver transplantation is another major curative option, often considered the best for certain patients as it removes the tumor and the underlying cirrhotic liver.
What are the outcomes like for those?
Pretty good for early stage. 5-year survival after transplant can be around 70%, sometimes even better. Resection survival varies more depending on tumor factors and recurrence risk.
What if surgery or transplant aren't possible, still early stage?
Then local ablative therapies come in, things like radiofrequency ablation, RFA, or microwave ablation, MWA.
How do they work?
They use heat generated by radiofrequency waves or microwaves delivered through a needle probe inserted into the tumor to basically cook and destroy the cancer cells. Very effective for smaller tumors, maybe up to 3 centimeters or so.
Okay. And TACE, you mentioned that earlier.
Right. Transarterial chemoembolization. That's often used for slightly more advanced disease, what's called intermediate stage according to BCLC, or sometimes as a bridge to transplant.
How does TACE work?
You thread a catheter up through the arteries into the hepatic artery, feeding the tumor. Then you inject chemotherapy drugs directly into the tumor, followed by tiny particles to block off the blood supply embolization. Traps the chemo in and cuts off oxygen.
Sounds quite targeted.
It is. It's not usually curative, but it can control the tumor for a significant time.
Okay, so that's early and intermediate. What about more advanced HCC?
For advanced stages where the cancer has spread into major blood vessels like the portal vein or spread outside the liver, metastasis, or the patient's liver function is poor, or they're not well enough for regional therapies, then the mainstays are systemic treatments, drugs that travel through the whole body.
Chemotherapy.
Yes, but traditional chemo isn't super effective in HCC. The big advances have been in targeted therapies and immunotherapy.
Targeted therapies, like...
The first breakthrough was sorafenib. It's a tyrosine kinase inhibitor, blocks pathways involved in tumor growth and blood vessel formation. Lenvatinib is another similar drug. These are often first-line options for advanced HCC with preserved liver function, child-TO.
And immunotherapy.
That's become really important too. Drugs like nivolumab or pembrolizumab or combinations like atezolizumab plus bevacizumab, these help the patient's own immune system recognize and attack the cancer cells.
So, lots of options depending on stage.
Yes, and often a combination or sequence of treatments is used. And crucially, alongside all this, you have to manage the underlying liver disease, treat the complications of cirrhosis, advise on alcohol, diet, lifestyle, especially for NAFLD. That supportive care is vital.
Great. Non-prescribing management is key too.
Absolutely. Address the root causes where possible.
Okay. So with all these treatments, what's the overall prognosis like for someone diagnosed with HCC?
It's highly variable. Really depends on that stage of diagnosis and the underlying liver health.
Early stage is better, obviously.
Much better. If caught early and you can do resection, transplant, or ablation, the outlook is significantly better. As we said, maybe 50–70% 5-year survival.
But most aren't caught early.
Unfortunately, no. Because it's often asymptomatic early on, many people are diagnosed at an intermediate or advanced stage. And that's why the overall prognosis for HCC is often considered poor.
Right.
The underlying cirrhosis really limits things too. It affects which treatment someone can tolerate and their overall survival. For advanced cases, if untreated, median survival might only be around 6 months, maybe a bit longer, with systemic therapy.
That's quite sobering.
It is. And liver failure itself is a major cause of death. Cachexia, bleeding varices, infections, kidney failure. High AFP levels at diagnosis also tend to correlate with a poorer prognosis.
So the key is really prevention and surveillance.
Absolutely. HBV vaccination is crucial globally. Sensible alcohol use, tackling obesity and metabolic syndrome for NAFLD. And for those who already have cirrhosis, that regular 6-monthly ultrasound surveillance is probably the single most important thing for improving outcome.
Because it allows early diagnosis.
Exactly. Catching it early means potentially curative treatment is possible, pushing that 5-year survival over 50%. It makes a massive difference.
Okay. And finally, what are the main complications associated with HCC itself, or its treatment?
Well, the main complication is tumor progression, obviously. The cancer growing and spreading.
Right.
That can lead to worsening liver failure. Portal hypertension can worsen, leading to more ascites or variceal bleeding. A specific complication is portal vein thrombosis, a clot in the main liver vein, often caused by tumor invasion. That's a bad sign.
Okay.
Metastasis, spread to lungs, bones, etc., is a major complication of advanced disease. And then, of course, the treatments themselves have complications and side effects, bleeding or infection, after procedures, side effects from systemic therapies.
And the underlying cirrhosis complications continue, too.
Yes, you still have all the risks from the advanced cirrhosis itself, like bleeding, encephalopathy, infections like SBP. It's often a combination of cancer-related problems and cirrhosis-related problems.
Well, that's a really thorough deep dive into hepatocellular carcinoma. It seems really clear that surveillance in those at-risk groups and thinking about the underlying liver health is just paramount.
Absolutely. Early detection and prompt, stage-appropriate management are key, always remembering that connection to chronic liver disease.
So for all of you listening and revising, definitely go back through your notes. Think about how these pieces fit etiology, risk factors, presentation, staging, treatment, prognosis, complications. How would you tackle an exam question on this? How does it apply clinically?
Yeah, connecting those dots is crucial.
And for more MSRA revision help, don't forget to check out PassThemSRA.com and also FreeMSRA.com. Loads of resources there.
Definitely worth a look.
Great. Thanks very much for joining us on the deep dive.